Hello, my name is Juliana Amorisi. I'm a nurse practitioner at the Pediatric Cardiac Intensive Care Unit at the Johns Hopkins Children's Center, the Blaylock Taussig Thomas Pediatric and Congenital Heart Center. I've been working with a multidisciplinary team over the past 4 years to improve patient outcomes through the introduction of early enteral nutrition for neonates undergoing cardiac catheterization procedures or surgical interventions within the first 30 days of life. I'd like to share with you today the work that we recently presented at the Pediatric Cardiac Intensive Care Society annual meeting in Austin, Texas. This is about our quality improvement research and the effects we have seen at this time. The importance of this work is that congenital heart disease is the most common congenital defect affecting newborns within this country. By introducing early enteral nutrition, research has shown that you can reduce the number of babies who need feeding tubes and increase the number of babies that are able to be orally fed at discharge, as well as reduce perioperative complications. We can also possibly reduce length of stay, both in the ICU and the overall hospital length of stay by doing this. Today, I hope you take away that by involving the multidisciplinary team and implementing feeding guidelines to standardize care, we're able to improve patient outcomes without adverse effects. The way we did this was that we had a multidisciplinary team involving nurses, physicians, nurse practitioners, dietitians, and speech therapists who have been meeting on a regular basis to first create feeding guidelines to help standardize who could be fed safely preoperatively, as well as how much to feed them. We also did a number of other interventions, such as standardizing speech therapy consults. We also did surveys to our team to understand how they felt that they were using the guidelines at the bedside, which led us to partner with the Armstrong Institute Human Factors Engineering team to redesign our guidelines to make them easier to use. We also created heart center focused donor breast milk guidelines to increase breast milk utilization, which has been shown to be safer for infants with congenital heart disease in the neonatal period. And lastly, we also created a team of nursing champions within our unit so that each shift should have a nursing champion present to help support the bedside team. For our results, we saw that we were able to make a statistically significant increase in the number of babies who were fed with specific heart disease that are usually the ones that are most at risk: babies with hypoplastic left heart syndrome, transposition of the great arteries, and other ductal dependent lesions. We also saw that we did not have an increase in necrotizing enterocolitis, so we were able to increase the number of babies with complex congenital heart disease that were fed, and that did not impact the rates that they might experience a complication from being fed early. We saw a trend towards a decrease in the hospital and the ICU length of stay, though this was not statistically significant. We, at this time, have not made an impact in the number of babies who required feeding tubes at discharge, and through further work, we hope to impact that number to improve patient outcomes. So, in conclusion, babies are able to be fed safely before a cardiac procedure in the neonatal period by standardizing and involving the multidisciplinary team for care in the ICU. I'd like to thank all of the team members that have been involved with this work over the past 4 years, and we look forward to seeing you again in the future.